Hello. Coming to the case study for biochemistry, we have myocardial infarction. So, how they will present the case is a 45-year-old obese male bank manager was a known diabetic and a smoker for the last 25 years. For the past 6 months, he was feeling mild chest pain when climbing the stairs. One night, he felt crushing chest pain which radiated to the left arm and jaw. He was sweating profusely and was taken to the nearby hospital. ECG revealed elevated ST segment and peaked T waves. So the indications for myocardial infarction over here will be 45 to 50-year-old. So basically they will generally put it in 40s to 50-year-old, and obese is another marker over here. Then you have a known diabetic and smoker. They will generally give smoker for myocardial infarction. And then you have crushing pain. Crushing pain is characteristic for MI. Crushing pain along with radiation to left arm. Radiation to left arm is also characteristic for MI. Sweating profusely is another indication. Now coming to the ECG, we have elevated ST segment and peaking T waves. This also shows myocardial infarction. Now the investigations that we're following are troponin T, total CK, CKMB, total LDH, and LDH1, LDH2. So what we need to focus on is total troponin T and CKMB. So here you have troponin T is highly increased. The normal value is 0.01 nanograms, but here you have 15. Same, you have total CK increased, creatinine kinase, and then you also have CKMB increased. LDH is also increased. Now all this gives you the myocardial infarction. Coming to the questions. So your probable diagnosis will be myocardial infarction, acute myocardial infarction. So to diagnose myocardial infarction, WHO has given a criteria. There should be clinical manifestations, there should be ECG, and there should be biochemical markers. So clinical manifestations may we had crushing pain, radiating to the left jaw. To the left arm. And then we also had sweating profusely. Then coming to the ECG, you had elevated ST segment and peaked T wave. Biochemical markers, the most important markers you will have is troponin I, then you have CKMB. These are the two most important. And then coming to how does the disease develop or the basis of myocardial infarction. So basically a clot forms in one of the major vessels. That clot will traverse and go into the coronary artery. When it occurs, ischemia is there, that is decreased blood supply. So if the blood supply to the cardiac musculature is decreased, you have decreased oxygen supply. So there is less oxygen. So instead of aerobic, you have anaerobic respiration. In anaerobic respiration, you have increased lactic acid, decreased ATP, and increased NADH. Increased lactic acid is important over here. Now this finally leads to infarction resulting in death of myocardial tissue. When you get death of myocardial tissue, that is when you get the actual myocardial infarction or the crushing chest pain. Then coming to the biomarkers, the most important is the highly specific troponin 1, highly sensitive troponin 1. This is 100% sensitive for MI. This is 100% sensitive for MI. And then you have it elevates within 3 to 6 hours of myocardial infarction and stays up to 1 week. So generally what happens is patients would have gotten myocardial infarction, but they are admitted into the hospitals later. So how do we check if they actually suffered an episode of myocardial infarction is by checking the troponin I. So because it stays high in blood for up to 1 week. And then you have CKMB or CK2, the second isomer of CK. It is more specific but less specific than troponin I. It appears in blood within 4 to 6 hours and comes normal within 2-3 days. Okay. And then you have myoglobin. Any muscular tissue has myoglobin. So this is not specific, but this is useful in early diagnosis because instant cell death, the myoglobin is released into the blood. So it is elevated within 1 to 4 hours of onset of myocardial infarction, but it goes down within 24 hours. So that's it for myocardial infarction.